Hello everyone and welcome to FLS Works. Today we're going to have a webinar in a few minutes, so we'll just let everyone join and we'll get started. So I'll give you a few more minutes and then we're going to get going. So thank you for joining us today. Today we're going to be hearing from Dr. Diane Theriault. Before we get started though, I was going to introduce you to our website, which is hosted on the Osteoporosis Canada website. And ours is called the Fracture Liaison Service Hub, or the FLS Hub. And on that website you can see lots of tools that are there. We have a registry that includes the locations of many of the FLSs across the country. We carry a registry that allows any FLSs in Canada to register with us, and those sites meet certain criteria, and once they meet those criteria, they end up on our map and within our network and our registry. Every month or two, we send out a liaison newsletter, and to be part of that, you just join up on the network, which is also there on our FLS Hub website. We offer a free consultation service, which allows you to benefit from the knowledge of Dr. Theriault as she guides you through the FLS process. And then we have our webinars that we offer on a regular basis. Many of our tools are in French, and they are also accessible on the website. Today, we are going to hear from Diane Theriault, as I said, and she's going to talk to us about the post-fracture care gap in the elderly. As we go through the webinar, if you have any questions, you may send me a question on the right-hand portion of your screen by putting in a question in that section. You can also send us a chat message if you see any technical issues or anything happening that you'd like us to know about. At the end of the webinar, I believe it's tomorrow, you will get a little survey, and if you wouldn't mind, it's a quick one, if you could send us any comments and your scores in there, that would be greatly appreciated. If you come up with a question afterwards that you didn't get a chance to ask today, then feel free to put it in that survey, or you have my email, I believe all of you that I see there, and you can certainly send me a question. So I'm going to turn the screen over now to Dr. Theriault, and she's going to talk to us today about the elderly.
Okay, so I'm hoping that you can all hear me okay, and that you can see my slide and my pointer. So we're going to tackle an issue that many FLSs have reported to us as a common theme in many FLSs, and that is that there is a care gap in osteoporosis post-fracture, but it seems to be more prominent in the elderly. So here's my disclosure, and of course I'm doing this as a volunteer for Osteoporosis Canada. Now, what gives me authority to speak on behalf of the elderly here? Well, I'm not a geriatrician, but I do get this document from the Nova Scotia MSI, that's our billing provider group in Nova Scotia, and they give us a breakdown by age of the patients we see. And here you can see the other rheumatologists in my province. 44% of their patients are over 65, but in my practice, which is limited to the management of osteoporosis, you can see that close to 80% of my patients are over the age of 65, and it's not unusual for me to have a full day at the office, and the youngest patient that I may have seen that day was in their mid-70s. So I'm going to start with a case. So this is a case that was given to me by one of our FLS nurses. So at the age of 84, she broke her wrist, and her family physician did a bone density test, found her to be at high risk, and started her on alendronate. The FLS saw her for the first time in 2016, and at that time, this woman was 88. She presented with a shoulder fracture. She was assessed by the FLS nurse, and it became obvious that the patient had been taking her medications in a pill pack for the last 2 years. And unfortunately, when she switched to the pill pack, her morning alendronate pill was put in the same little blister as all of her other morning medications. So unfortunately, Mrs. G was taking her alendronate tablet with breakfast and her other morning pills for the last 2 years. So the FLS fixed the pill pack. The family physician supported this, but 2 months later, a geriatrician saw the patient and recommended that the alendronate be discontinued as, and we're quoting the letter, the risks outweigh the benefits due to the patient's age. So we're going to explore what's right, what's wrong, what's the connection between osteoporosis, fractures, the benefits or the risk of the osteoporosis medications, depending on age. So we're going to focus on the fractures, on the secondary fracture prevention, on some of the misconceptions out there, on the care gap in the elderly, and then I will briefly mention the long-term care guidelines for osteoporosis, which are Osteoporosis Canada guidelines. So this picture shows what we often see, which is that many of these fractures will occur following a fall. And you see this woman here who might end up with a broken wrist, and this woman here who in the elderly, in the older age group, the fall is different. The patient is no longer walking fast. They don't have a lot of reflexes, or good reflexes are gone. And so they fall sideways or straight down and end up with a broken hip instead of a broken wrist. Now, the fall did not cause the fracture because, in fact, only 10 to 15% of falls in the elderly lead to a fracture. So obviously, a patient who falls and fractures, they have two separate problems. One is the propensity to falls, and the other is the fragile bones, or in other words, their bones fail them. And so two different problems, and obviously we want to address both. But for the purpose of this presentation today, we're going to focus on the bone part of this. Now, with osteoporosis, you do not need to fall to break a bone. So this is my very simple depiction of a vertebral body. They're typically square in shape, and you're seeing them from side to side here. So this is the front, and this is the back. And when these bones fail, they collapse down. And as you can see, because most of your weight is in the front, they tend to collapse a little bit more in the front than in the back. We call that a wedge compression fracture. But typically, as you know, osteoporosis is a very systemic disease. So it doesn't affect just one vertebral body, it affects all of them. So typically, if you got this first fracture from just lifting your grandchild, for example, then it's a matter of time before a second and a third one will occur. And that ends up with a kyphosis, a very accentuated curve in your back. So here's a woman who's in her 20s with a nice straight back. Here she is shortly after menopause, and she already has 2 vertebral fractures. Here she is a few years later, and you can see that she has a severe kyphosis now. And this is not a cosmetic problem. This is a real illness. This woman has lost several inches in height, and all of that height loss is really in her trunk. So all of her internal organs are compressed. And so she's shorter of breath. Men and women who break bones in their spine, they're sicker. They spend more days in bed and more days in hospital than other men in age and women of their age group who have not fractured. And after that first broken bone in their back, the mortality risk is significantly increased. It's doubled for at least the first 2 years. The hip fractures also have very poor prognosis. It's a life-altering moment. Less than half will ever recover the full level of independence that they had prior to their broken hip. In close to 20% of cases, it will mean that they no longer can cope in their own home and they will have to be transferred to a nursing home. And 23% of women and 36% of men will die in that first year following the broken hip. Now, who are the individuals who break bones? Well, there certainly is a clear correlation with age. Here you can see the annual incidence of fractures based on age, and you can see that the older women get, the risk of fractures starts to skyrocket. And in men, in red here, you can see that after the age of 65, you can see that same very pronounced increase in the risk of fractures. Well, it wouldn't matter a whole lot if they were the less severe fractures. So what type of fractures do older men and women suffer? Well, you can see the vertebral fractures, which we've already looked at, and we know that they don't have very good outcomes. You can see that that goes up quite significantly with age. And for hip fractures, the very same thing. So this is men here and women, and you can see that, again, it skyrockets after the age of 70. So obviously, this is a problem that gets more frequent the older we get. So I want to move to another issue, which is the fact that fractures beget fractures. After a broken wrist, about 15% of patients will return with another broken bone within the next 3 years. So that's certainly moderately elevated. But after a vertebral fracture, 1 in 5 will come back with a second vertebral fracture within 1 year. So this is a very, very high risk. What about the broken hip? We often think of the broken hip as the end of the road. Well, not quite so. So here's an 85-year-old woman, and she slips and falls and ends up with a right broken hip. Here she is 2 years later. She's had another fall, and she's broken her wrist. And here she is 2 years later. She's broken her left hip this time. And she did not fare so well. So after her surgery, she ends up with a heart attack and ends up in the CCU. She needs blood transfusion and goes into congestive heart failure. So obviously this is one of these patients who've had a very poor outcome following their broken hip, one of those statistics. The fact is that the broken hip is the queen of all fractures in terms of predicting future fractures. So within 1 year of breaking that first hip, there's close to 10% chance of breaking the other hip within 12 months. And if you don't do it within the first year, there's a good chance you will do so in the next 5 years. If you don't break a hip again, you'll probably be coming back with another broken bone. So this is certainly a group that is at extremely high risk for fractures. So after that first fracture, the risk of a second fracture is both high and imminent, particularly so for hip and spine fractures. So do we have medications that can reduce that high risk of fractures? And this is from the 2010 Osteoporosis Canada Guidelines, looking at the ability of our osteoporosis medications to reduce the risk of vertebral, hip, and non-vertebral fractures. And you can see that we have well-rounded medications that can reduce the risk. I should add to that that there's a more recent study that showed that teriparatide is even more effective than risedronate to reduce fracture risk. So obviously it's another well-rounded medication. How about the imminent? How quickly can we reduce the fracture risk? Well, we actually have a very good ability of reducing spine fractures within 12 months of starting treatment. As you can see, pretty much with all of our drugs, you can reduce the risk in the order of about 60% within the first 12 months. So not perfect, but certainly our drugs work relatively well and relatively quickly. So we know that our medications work at reducing fracture risk, and they work relatively fast. But there's been some concern in the literature or expressed by people that maybe our osteoporosis medications don't work as well in the elderly. So I would like to review some of the evidence that we have. So for sure, the early studies sort of excluded the elderly. So if we consider the elderly as individuals over the age of 80, this is the first landmark study of alendronate, and it was all in women, and you can see that the top age was 81. So large study with large group in placebo, large group in the alendronate group, and it significantly reduced vertebral fractures as well as hip fractures over the course of 3 years. Do we have anything to say that this will work in the elderly, the patients over the age of 80? Well, there was a big systematic review of 11 trials, which included over 12,000 participants, and they looked at the reduction in hip fractures, and they looked at all the age groups, and the 40% reduction in hip fractures was independent of age. So it worked just as well in the older population as in the younger population. This was a Swedish study, and it's an interesting study. So this is not a randomized controlled trial, but it is sort of attempting to replicate that. So this is in a large falls prevention screening program that was running between 2008 and 2014. Every single participant in the screening program was over the age of 80, and in fact, they had close to 500,000 patients in this. And they screened the patients with any prior fracture within the preceding 4 years. So they were looking at patients who had already fractured. And one arm of this was the alendronate naive patients. So they'd never been exposed to alendronate. Then they fractured. And then following their fracture, they were started on alendronate. So that's going to be the alendronate arm. And in fact, they found close to 2,000. And then in the other 52,000 patients who had fractured and had never had exposure to alendronate before they fractured, and also did not have alendronate afterwards, they matched them 4-1. So that will become the control group. And they matched them for many characteristics, so sex, age, height, and weight, and bunch of other things, and we'll go through some of them in the next slide. And they ended up with a control group of close to 8,000 patients. So in terms of looking at some of the matching, you can see how very closely matched the two groups were. So mean age was identical in the control arm versus the no alendronate arm, versus the alendronate arm. So again, previous hip fracture was the same. Previous vertebral fracture was pretty much the same. Dementia in both groups was the same. The only thing they couldn't perfectly match was a prior diagnosis of osteoporosis in the chart. So for obvious reasons, the group that were offered treatment, it was more frequently mentioned in their chart that they had osteoporosis. That's the only thing that was statistically significant, although it wasn't very different either. So they watched these patients until death, or they emigrated out of Sweden, or to December of 2014. And they looked at these outcomes, whether they went on to develop a hip fracture, a major osteoporotic fracture, which would be hip, wrist, shoulder, or spine, any fracture, death, or any adverse events. So this is looking at hip fractures, major osteoporotic fractures, or any fracture in the alendronate group and what I would call the placebo, but it's really a control group here. And you can see it doesn't matter which group you're looking at, there was a statistically significant difference, a reduction if you were in the alendronate group compared to the control group. And the numbers needed to treat were very respectable, in the order of what we would normally look at, and this was at 3 years. So a fairly short time horizon. In terms of looking at the side effects, there was a slightly increased risk of mild upper GI tract symptoms in the alendronate group, but you could see it was still very low, 2.3%. But there was no difference in peptic ulcers or in deaths. In fact, if you look at the death rate, it was a little bit better in the alendronate arm than in the control arm. So here's another study looking at risedronate, because again, there's been concerns expressed that possibly our medications have more side effects in the elderly than in younger population. So this is looking at the bunch of randomized controlled trials that were done for risedronate, but they were looking only at the patients that were over the age of 80, or in these. So some were assigned to placebo, some were assigned to risedronate. And in terms of the adverse events, you can see that there's absolutely nothing here that reaches statistical significance. So no difference in nausea, abdominal pain, dyspepsia, vomiting, etc. But in terms of the mortality, again, if you were worried that our medications are deadly, well, they're certainly not, because more patients died, although it was not significant, in the placebo arms than in the control arms. So obviously not seriously dangerous drugs. And in terms of the serious adverse events to risedronate, if you looked at esophagitis, stomach ulcer, duodenal ulcer, there was no statistical difference between both groups, whether they received placebo or risedronate. So all very reassuring. Now, in the early trials, of course, there were very few patients overall that were over 80. In the more recent trials, there's been a real effort made to include more elderly patients. So one of the pivotal trials was with the denosumab, the randomized controlled trial. And this, instead of just going to age 80 or 81, you can see they're now including patients up to the age of 90. And in the study, about a third were over the age of 75. So this is what they saw with the entire group of patients. So that's from 60 to 90. So you can see that this reduced the risk of hip fractures significantly. And I think you can appreciate that the two lines start to separate very early on, well before a year. But in the subgroup analysis of only the patients over 75, they looked at hip fractures at 12 months. Well, 2.3% fractured in the placebo arm and only 0.9% in the denosumab arm. And this was statistically significant. So at 1 year, denosumab in the elderly had shown decreased hip fractures. So obviously, it does work in the elderly. So if we look at all of the evidence, and of course I've only presented to you a very tiny portion of the evidence. What we do have is less evidence in the elderly than in the younger patients, okay? But having said that, what evidence we do have, supports that our drugs work just as well in the elderly as in the younger people, and we have no evidence whatsoever that there are more side effects in the elderly. So, in essence, we can accept that our medications, our osteoporosis medications, work just as well for the elderly as everybody else. But then I have this expressed to me all the time by family physicians and sometimes by family members of patients. So my patient won't live long enough to see the benefits of the osteoporosis medication. So then it becomes the ability to predict how long your patient's going to live, because I've already shown you that my medications can start reducing osteoporotic fractures within 1 year of starting treatment. So I'm not an expert at predicting how long a patient is going to survive. I did look up, and this is what information I was able to obtain from my research. So there are multiple tools to predict a patient's life expectancy. In general, it's not an exact science, and also the tools that are available are not all easy to use. But in day-to-day life, I have patients in my office in front of me, and I have to make a clinical decision today based on what I have. So here's what I was able to find from Stats Canada. The average life expectancy at birth of Canadians in men is 78 years, women 83. However, if you look at the average life expectancy in individuals who make it to age 65, then you can see that a man of 65 has an expected average life expectancy of 18 years, which would bring them to 83 years old. And in women, to bring them to 86 years old. And that's because if you manage to make it to 65, you probably have better genes than the other patients who did not survive to 65. So that's likely the explanation for this. But this is as much information as I was able to draw from the StatsCan website. On the US website, however, you can get a whole lot more information. So if you look at the US, you can see that a man who survives to 75 has an average life expectancy of 11 years, and a woman has close to 13 years. But I want you to look at the bottom of this range. A man who lives to be 100 still has an expected 2 years of life expectancy on average, and a woman 2.3 years. So I must say that I'm of the opinion that we cannot make a blanket statement of an upper age limit to our drugs. It would be really discrimination against the elderly to say a blanket statement that, oh my God, they're 100 years old. Obviously, we're not going to start an osteoporosis medication. Well, if their average life expectancy is 2 years and my drug can give them benefits in 1 year, then if we can prevent that next broken hip, then they are warranted for treatment. Here's the other objection that I get. My patient has way too many comorbidities or has dementia, so why bother? Well, here's a list of comorbidities that are associated with the elderly. And I've put down what the findings are in terms of bone density. As you can see, in many diseases, the bone density goes down compared to individuals who do not have that condition. And you can see that the falls go up. But in all of these conditions, the fracture risk goes up. So obviously, the more comorbidities a patient has, the worse their risk of fracture is. So to me, that is not an indication not to treat. That's more reason to treat. But I do want to focus on this one here, dementia. This is a study that was done in Sweden. It was looking at community dwellers age 65 and up who were followed for 4 years. And you can see that the patients with dementia were more likely to fracture than the patients without dementia. And that fits with what we've just said a minute ago in the last slide. But they also looked to see what were the predictors of being started on treatment. Well, uh, here it is. Patients with dementia were least likely to be started on treatment than the patients without dementia. So the patients who are at more risk should be getting treatment. And it's the exact opposite that's happening. Here's another study. This one was done in the US. This is a very large study, over 100,000 US women, 65 and up, and they'd all suffered a fracture in the calendar year 2011. Only 27% were treated with osteoporosis medications within 12 months of fracture. And by the way, that group suffered 21% less fractures than those women who had had a fracture and were not given an osteoporosis medication. So another indication that our drugs work. Most predictive to get treatment, and this one's quite discouraging. The most predictive was patients who were already on osteoporosis medication before they broke, so they were just simply continued on treatment. But one of the most predictive for not being offered treatment was dementia, those patients that are most at risk. What about long-term care residents? Well, we have lots of studies in long-term care. Depending on the studies, 10 to 25% of long-term care residents have had a prior hip fracture. And in fact, many patients will be going to long-term care specifically as a result of that broken hip. So it's not surprising that, a good chunk of the patients will be there, have had a previous hip fracture. But hip fractures occur in long-term care as well. So the absolute rate of hip fractures in long-term care varies from 3 to 6% annually. I mean, this is very high. Remember, we usually consider patients who have a 20% risk of fracture in the next 10 years as high risk. And this is the risk of hip fracture alone in 1 year. This is huge. The rate of hip fractures in long-term care is 3 to 11 times that of age and sex-matched peers in the community. We did look at our hip fractures coming from long-term care in Nova Scotia. Over the span of 5 years, it accounted for anywhere from 10 to 14%, with an average of 12% of all hip fractures coming directly from long-term care. So certainly it is a big chunk of the problem. This was an interesting study. It's quite a large study looking at long-term care residents. They were two groups. One group had had a prior hip fracture before admission, and the other group had never had a prior fracture. So you can see one group, there's 7,000, the other group, there's 22,000. But look at how high the risk of fracture is in the patients who had had a prior hip fracture. So within 3 months of admission to the nursing home, 7% had already gone on to break. By 2 years, a quarter of them had gone on to break. And you can see that the risk is much higher than the other arm. So obviously, that is a huge predictor of future fractures, even in long-term care where patients have much greater supervision. So the other part of this equation is, what do the elderly want? Do they want to prevent those fractures? And the answer is yes. So this was a survey of close to 200 women, all older than 75. And 80% said that they would rather be dead than have a hip fracture and lose the independence and quality of life subsequent to that. So certainly that is something that the elderly do fear. We have another glimpse at this because the Osteoporosis Canada Long-Term Care Guidelines, which were published in 2015, used the grade approach in terms of determining these guidelines. So on top of being evidence-based guidelines, they also incorporate the values and the important aspects of stakeholders. And the stakeholders included the authors, multidisciplinary healthcare professionals, and very importantly, representatives from residents of long-term care and also family councils from long-term care who represented these residents. And here are the important outcomes by that group. So, decrease fractures, decrease pains, maintain quality of life, not losing activities of daily living or mobility, not dying, and reduce adverse events requiring medical attention. So these were the adverse events that they wanted to avoid. So in this grade approach, when they say recommend or strong recommendation, what that meant for patients or long-term care residents was that most individuals in this situation would want the recommended course of action, and only a small proportion of those patients would prefer not to. For clinicians, it means that most individuals should receive the intervention or treatment. So let's have a look at what's recommended by these guidelines. So they recommend a fracture risk assessment upon admission, and I'm adding this to it because it's in there too. And again, if there's a fracture during the long-term uh, um, um, stay. So here are the risks. If they had a prior hip fracture, and of course we already looked at that data, if they had a prior vertebral fracture, if the patient had had more than one prior fracture. So for example, 5 years ago they had a broken wrist, and 3 years ago they had a broken shoulder. Have they been recently on glucocorticoid like prednisone in the last year and had had a prior fracture? Were they previously assessed as high risk for fracture and they were receiving treatment prior to admission? And was there any vertebral fracture detected? For example, if there was a chest x-ray done at the time of admission to the long-term care facility. And this is the same one here, but if ever they have a fracture that required assessment in the hospital when they return, this needs to be looked at again. If it's yes to any one of these, then the resident is considered high risk. And we're going to look in the next slide at what is recommended by these guidelines. So we're only going to look at this side of this chart. So strongly recommended calcium supplementation if they cannot consume 1,200 milligrams a day through diet, vitamin D supplement of at least 800 units, and hip protectors for those who are mobile, and that is whether or not they're supposed to be mobile. So if they're getting out of bed, hip protectors would be recommended. And on top of that, there's a strong recommendation to use one of the following: alendronate, risedronate, denosumab, and zoledronic acid. These are the 4 drugs that were already listed in my prior slide where we were looking at the recommendations from the 2010 guidelines. So no difference in recommendation. The only thing that's written in the small print here that's important to know is that this should apply to the elderly with a life expectancy greater than 1 year. And that's because our medications do take about 1 year to give that benefit on fracture risk reduction. Now, are these guidelines controversial? Not at all. For the most part, they're very consistent with long-term care guidelines that have come out of Australia and the ones that have come out in the US. If we say this for patients in long-term care, I would surmise that we should at least recommend the exact same thing for elderly patients who live in the community. The one thing that is a little harder in the elderly, however, for our medication is elderly patients are more likely to have chronic kidney disease, and most of our osteoporosis medications are contraindicated with the eGFR of less than 30 mils per minute. In patients who have reduced eGFR, denosumab is an option, but it does require a bit of careful monitoring for the risk of severe hypocalcemia. So in terms of when I say careful monitoring, it just simply means a blood test before each denosumab injection and a repeat blood test approximately 10 days after the injection. And certainly they still require treatment. And if the prescriber themselves or the primary care physician is not comfortable prescribing, certainly consultation to an osteoporosis specialist would be indicated. So this is the guidelines. And again, this is for long-term care residents. Is the resident lifespan greater than 1 year? If it's expected not to be, then you should not start treatment. If it is greater than 1 year and the creatinine clearance is greater than 30 mils per minute, then you would just simply ask the regular questions that we would ask anybody in any age group. So if the patient has dysphagia, then we would have to go with a non-oral medication. If the patient does not have dysphagia, can swallow easily, then any of these options that we mentioned are recommended. If the patient has low creatinine clearance, then denosumab is recommended provided the creatinine clearance is greater than 15 mils per minute. And if you're not comfortable, then consider referral to a specialist. Again, this is for long-term care residents, but at the very least, we'd recommend the same thing for patients in that age group who live at home. When they live at home, it's a little bit more complex. Many patients will be at home with early dementia, and for the most part, they function relatively well. But the oral bisphosphonates are tricky in terms of how to take them. They're once a week, and some of them are once a month, and so they're more easily forgotten. They have to be taken on an empty stomach, and so patients with early dementia or with some confusion may forget and take their pill with food. And remember that first case I started this presentation with, it's not unusual that they're taking their pills in a pill pack, and even pharmacists forget and put the pills in the morning blister, which would end up with the patient taking it with food and therefore not absorbing any of it. So parenteral in early dementia would be ideal for many patients. I do put a word of caution. The parenteral only works if the patient returns for their second injection and third injection. And in particular with denosumab, it's very important that they stay on their every 6-month schedule. What about the long-term care facilities? How accurately are the medications being administered to patients? And this is from the Hamilton area, and they looked at 8 long-term care facilities and looked at the RNs who were administering the oral bisphosphonates, and only half of them knew how to give the bisphosphonates correctly. 15% would give it with or after breakfast, which means no absorption. 10% would give with juice or milk, again, no absorption. A third of them would give them with all of the other morning meds, and we certainly hear this because it's a much more convenient way to administer medications to patients in long-term care facility, but unfortunately for our patients, it means they will not absorb their bisphosphonate. And this one is more concerning. About 1 in 5 were quite okay to give the patient the medication and then let them lie down again. And that's actually quite dangerous. That's the patients who get a complication with esophageal ulcers. Now, this is not just Hamilton. I can tell you that I know this to be happening within my own province in Nova Scotia. And in fact, we had a meeting of our Canadian FLS coordinators in May of this year. And this was evident in pretty well every province where there's an FLS. That was one of the uh, barriers to effective treatment that was highlighted by the FLS coordinators. So it is not a rare issue. So because of that, we've developed at Osteoporosis Canada a tool. This is a poster that's meant to be um, uh, posted in the med rooms of long-term care facilities, which shows very clearly that the medication needs to be first thing in the morning on an empty stomach with that full glass of water, that they cannot take any other food or drink or other medications, that they cannot crush or chew the medication, and the patient cannot lie down after their dose. So, hoping that this might help make this information more visible. So, I'm going to end with a case. When we have patients develop more than 2 fractures in the vertebra in 1 year, we say this is a vertebral fracture cascade. This is a very serious situation. Patients will go on every month or 2 and break another one and another one and another one. So this is Mrs. D. I first saw her in 2012, but here's her story. So at 81, so this is definitely, we're speaking a patient who was elderly. She broke her wrist, but nobody thought of osteoporosis. So no treatment was offered. At 93, she broke her hip. Nobody thought of osteoporosis and no treatment was offered. In 2012, at 96, she had 3 vertebral fractures in the same year. So this is a vertebral fracture cascade. The first one was asymptomatic. It was picked up on a chest x-ray. It's obvious that it was a new one. I reviewed her x-rays and it wasn't there the prior year. But the last 2 were very painful, and both times she ended up in the emergency department with a very painful fracture. And it's only after that second painful fracture that she was finally considered for the possibility of osteoporosis. So here she is at 96. She's come in to see me for the very first time. At this point in time, she hadn't even been offered vitamin D. So my approach was to offer her to give her advice on safe movements to try and reduce the risk that she would end up with a third painful vertebral fracture. I started her on vitamin D and I started her on alendronate. So this is a 96-year-old woman. I started her on alendronate and we got very lucky. I kept seeing her initially frequently, but eventually just once a year, and she remained fracture free. I last saw her in January of 2016. She was 99. She was still on her alendronate and doing well. She had good blood tests. There was no indication to stop that alendronate. 2 months after I last saw her, she moved to a long-term care facility, and the first thing they did upon admission was discontinue her alendronate. Well, to me, it's extremely clear what's going to happen next. A patient who's had a fracture cascade like this, you stop the medication, she's going to start breaking again. So these breaks occur not from falls, they're just from coughing or sneezing. So she's either going to die or else she's going to live a little longer and she's going to break again. And she showed up in May of 2017, okay, just a little bit over a year after she'd been stopped her alendronate, after having been perfectly stable from 2012 to 2016. But within a year of this, she's back in the emergency department with a T7 fracture that occurred from no falls. As far as the nursing home nurses thought that it had occurred from a sneeze. Guess what I did? I started her back on her alendronate. There was no choice. But quite honestly, we failed this woman at several steps of the way, possibly because she was always felt to be too old to be started on treatment. I think this is a real shame. So the take-home message should be never to ignore a history of a prior fragility fracture, no matter how old the patient is. And if the patient has a life expectancy of a year, if there's a reasonable expectation that they might survive a year, then you should treat if that prior fracture was hip or spine, or if they'd had more than one fracture. You should treat them if they've had a prior fragility fracture and they're either on prednisone now or they received prednisone treatment within the last 12 months. If they had a prior wrist or prior shoulder fracture, then you would treat if they're high risk, and that is based on either bone density and fracture risk determination, or if the patient cannot go for bone density tests, you can do fracture risk using FRAX. But at the very least, you should never just automatically stop a patient's osteoporosis medications. You should always assess the patient's fracture risk first before you go there. I would certainly submit that my patient, there was absolutely no harm to be had from her continuing on with her alendronate, but you can certainly see how she's fared poorly once the medication was stopped. So I will take questions at this point. So I will just see if there are any questions.
Thank you, Diane. And yes, if you have questions, there is a box in your middle of your right-hand screen that you can type a question in. And I'm looking at that now, and I see no questions just yet. So I'll give you guys all a few minutes to think of a question. And again, if you have a question that you'd like to send into us tomorrow with the survey, then feel free to do so. And otherwise, we'll give you a few minutes and see if there's something that comes up.
So I think it looks like there's no questions coming in. Can you tell if anybody's typing, Alouane?
Yeah, I see that there's no questions that I can see in either the question or the chat box. So I will, on behalf of you all, thank Dr. Theriault for sharing with us this great presentation on the elderly, and hope that we can continue to affect some change in this population. This webinar has been recorded and will be posted on our archived webinar series in the next week or so. So it will be there if you want to share it with somebody. And thank you all for attending, and we will see you next time with FLS Works.